Okay, guys, so I'm here on the Physio and Fitness podcast. I've got Mehmet and Glen on the call. We're very excited about today's chat. We've already been chatting about all sorts of things, which I wasn't recording, luckily for everyone. Today's chat is going to all be about hips. So both Glen and Mehmet are experts in the hip. They're specialists. They've both got courses. They've both got a whole host of experience with hip patients and lots of other physio patients, and I've worked alongside both of them in various different times in my career, so both really good guys. So I think today's podcast is really going to be about hip pathology and just talking about the hips in general. So I think I'll kick off the podcast really with kind of just a more generic question I had for both of you, really, which is kind of what got you into physio. So I think it's always interesting to hear people's backstory of what actually led them into that physio. So if we start with you, Mehmet, in terms of your history, just what got you into physio, what interested you in physio in the first place?
Yeah, well, look, thanks. Firstly, thanks for having me. I appreciate it. I'm always kind of keen to indulge my love for hips and geek out in any kind of way, shape, or form. So I appreciate that, mate. So what got me into physio? I'll be completely honest with this because I think my story kind of hopefully will help reassure some people that are at uni or going to uni or in that kind of situation. But I initially, I knew about physio through my passion of football and sport. It's obviously in the limelight a lot. Everyone kind of knows about what physios do a little bit more so now than before. But I had some family members, I think when I was younger, I mean, I can probably think back when I was like 12, 13, when I was kind of around physio itself with family members going for appointments and stuff. I was kind of wondering, like, what they're doing. Like, 'cause I think I went to an appointment and saw the physio gym. At the time, I thought that was really impressive. Obviously, now when you see a physio gym in a hospital with a Swiss ball, you probably would think it's not that impressive. But to me at the time, I was like quite intrigued as to what they did. And that kind of sparked a little bit of interest. I kind of looked into it a little bit, figured out that I liked science, I liked medicine, but I wasn't the most academic. I wasn't one of these people that would just like get all straight A stars, all straight A's. I had to kind of work to get what I wanted to get to. So I kind of thought, physio might be a nice avenue for me to kind of do that without the intensity of doing medicine, for example. So actually kind of fast forward to college, did all the kind of stuff that I needed to, probably wasn't as motivated as I should have been. And I ended up applying for physio, getting in, but not getting the grades I did. So I ended up doing a sports science degree at the University of Hertfordshire, still wanting to be a physio. But I thought in my head, maybe if I do a bit of sports science, I can switch over to physio. Like what naive thinking when you're 18, you just think life's that easy. But actually, my passion for sports and exercise science grew as I did that undergrad degree. But I still always knew that the thing that interested me most was like injuries, physio, that kind of subject. So then, I just looked into ways that I could then become a physio having done that. And then I ended up doing a pre-reg master's pretty much. I started 2 months after I finished my undergrad. I definitely wouldn't change it at all. I think a lot of people get worried about things sometimes don't work out when they're trying to get into uni, or they get into uni and they think options are limited. Mine wasn't a direct route, but I definitely wouldn't change it. I think that's definitely shaped me as a physio for sure.
What about you, Glenn?
Mine, well, it's a long time ago now. I think it was about 27 years ago when I had an injury, sustained an injury. I was on a school trip, messing around with a few mates, ended up falling off a 60-foot cliff.
Wow.
Spent the rest of the holiday in hospital, had about 9 months of rehab after that. And that was it really. So, I mean, going back to what you were saying, Mehmet, when I attended my physio, there was lots of interferential machines, ultrasounds, all these gadgets. And I thought, wow, this is pretty cool. And I attributed a lot of my improvements over that 9 months down to all these machines. But, that being said, the guy that was rehabbing me, he had a long history rehabbing people in the Navy, in the military, gave me a very structured program, and started a love of exercise and a love of physio, and followed it on from there really.
I guess that this follows up really from that, and obviously we're talking about hips today on the podcast. So what both led you both to the hip in terms of what's interesting about the hip, why specialize in the hip, or why go into the hip? And that can be for either of you to mimic.
I mean, mine is literally like a carbon copy of your last answer, Glenn. Which is, I just feel like it's the same for any physio that's a specialist in something. They've got some way, like some experience of it. But this is probably going about like 10 years back. I used to play football, like really like shit. Like I weren't great. I didn't play football that well, but I used to play quite a lot. Big fan. And I remember I used to kind of like, I was finishing football. I was thinking, groin's a little bit tight. Doesn't matter, I'll stretch it out. And I was kind of, just about to start to be a physio. It was in that kind of early stages. So I like to thought that I knew some stuff anyway. But and then that kind of like groin pain got worse, and then like the level of football that I was doing got kind of like the amount of time I could play got less and less and less. And then apologies, I just had a phone call there from my father-in-law. Very rude. And then I started to, just couldn't play as much. I remember one day I went to sprint from kickoff and I couldn't run. I just thought, this ain't right. And then, fast forward a little bit of time, and I ended up being diagnosed with FAI. And this was kind of, again, this is 10 years ago. So it's much more in the limelight now, but not so much back then. And I was trying to kind of just figure out what to do about it, and then ended up ultimately having surgery. And then my passion for it pretty much grew from then on, because I spent a lot of time researching about it. I had no idea what it was, how to manage it, how to treat it, what to do with it. And then that kind of sparked my interest. And then that was the catalyst of me then going down the avenue into looking at the hip in general. And it's interesting because those people like get scared of the hip. For me, I like it. I think it's really interesting. I think there's like, much worse joints that you could be a specialist in that aren't going to be as sexy as a hip. I mean, when do you ever get to deal with groins and bums on a regular basis? But and it be not frowned upon. But I love it, and it's kind of like progressed from there really. And I guess yes, it's interesting because I've spoken to other hip physios and hip specialists, and someone's got some story about something they've had with an injury at some point. I mean, Glenn, if you
was that, I was going to say, was that like was that like you, Glenn, or what was the?
Yeah, well, it sort of developed over a bit more of a slow burner with me. So when I first started in private practice, one of the clinics where I was based in Hertfordshire had a policy that only male therapists could treat male groins, and for the majority of my time there, I was the only male on the team. So I used to get all of the male groins. So that was how it started, I suppose. I did have a significant adductor pathology myself. That I had to kind of research and rehab on my own. And as you're aware, Chris, I had a hernia as well, inguinal hernia, as a result of me and you competing on heavy deadlifts.
Yeah.
So yeah,
obviously you lost then, Glenn. Yeah.
Well, depends how you look at it. I would say I definitely lost having getting a hernia. But,
I can't remember what the numbers were at that time. I just remember being on WhatsApp all the time, being like, "Oh, I just got 3 sets of this or 2 sets of this." Just thinking, "Oh yeah."
It's more into my brain. It was 3 reps, 200, but then the groin gave out. So yeah, it started off as a bit more of a kind of forced thing, really. That I was just getting a disproportionate number of male groins, and then over time realised there's such a gap, really, especially as you were saying, Mehmet, especially going back like 10 years and stuff. There was such a lack of knowledge in that area, and everyone was just being lumped into OA, and there wasn't many diagnoses, and there wasn't many routes for people to go down. And it used to take about 3 to 5 years, I think, is the data on them to get even a diagnosis. And they used to see about 4 different healthcare professionals. So I just saw that there was a big need there, really, and like you say, exciting area, fast growing, very interesting to read around and to work with.
So I think Mehmet mentioned something there as well about people being scared of the hip and almost being worried about the hip. And I think the reason why a lot of people are is because it's an area where there's uncertainty maybe about diagnosis, as you were just saying, Glenn, there, about there's different diagnosis. Like, is it the hip? Is it the lumbar spine? Is it what are we dealing with? And when you've got especially complex patients with maybe some comorbidities and stuff, it's difficult sometimes to pin it down to being the hip. So I guess it kind of leads on to my first sort of topic I wanted to discuss today, which is like, say you get someone in, what are kind of the sort of key subjective things you'd be looking for, or the things that you start to make you think when you see a patient and they start to tell you things, you think, okay, this is likely going to be a hip pathology, or this is, you know, in keeping with the hip pathology? For those physios out there that are looking for kind of key subjective things, Mehmet, what would you say that you're looking for with a hip, with a hip patient?
I mean, I'm quite passionate about the fact that we can pick up a lot of this just through that first chat. A lot of the information that we get from patients who are hip, that if we just kind of class them as hip or pelvic patients, they're going to give us so much information before we even worry about kind of doing clinical tests. And that's like something that I'm really kind of like focused on educating people, because a lot of the time when people aren't too sure about hips, their first thought is, what test shall I do to help me diagnose that thing? Well, actually, even knowing someone's age is already going to help you, give you an idea of what things it could be. Now, for example, if we just make it really simple and think, if someone's coming in with hip pain, first we've got to know, what does that hip pain mean for them? Like, what is it? What is it? Groin pain? Is it buttock pain? Especially nowadays, people are doing like phone consultations or like telehealth. And that patient could be saying they've got hip pain, but like, what's the hip to them? Like, it could be like their iliac crest, it could be their bum, it could be anywhere. So I think location and source of pain is key to start with. And then age, age is an easy differential, because if you've got someone who is 80 years old who's complaining of groin pain, you're not going to say, well, I think you might have an adductor tendinopathy, or you might have like FAI, for example, because it's unlikely. But you could flip that. You could be 21 and still potentially have an arthritic hip, but it's just about like, what are the common patterns that you could potentially recognize from those subjective questions to start with, and then take it from there. I think, especially, I think we can't really rule out and disregard the importance of red flag questioning with hips as well, because I think it's easy to sometimes just associate that so much with like the lumbar spine or just spine in general. Glenn, you probably agree, it's like one of those things actually with the hip, when it's, for me, the red flags are when things like sometimes just don't fit. You're asking the questions, you're going through examination, you're thinking, that this patient is young and active and they've got groin pain and it's worse when kicking and the hip is clicking and it kind of fits, and then sometimes it doesn't, and then you think, okay, well, like, why is it not fit? Why isn't it fitting? Like, what do we need to do? What kind of questions do we need to kind of look into?
I was going to say, I think we'll come on to the red flag stuff, because that is really interesting, and I think I definitely want to chat about that in a second. Going back to the subjective stuff, are there any like particularly aggravating activities you typically would see with like a hip pain patient?
Yeah, I mean, like normally, like, common things that they'll suggest is like issues getting in and out of a car. They'll say that their hip clicks. They'll have difficulty putting shoes and socks on. If they're sports man or woman, they'll struggle to sprint or kick a ball or really have that kind of initial explosive power. And then their common pattern is, especially like, for example, FAI, they'll say, similar to what I alluded to with my history, and the fact that, their ability to do sport gets less, or their ability to run and the volume and the intensity, everything gradually gets less. And the irritability of their symptoms is prolonged post aggravation as well. So those are quite like unique factors, aside from like, the clicking and the giving way of the hip and stuff like that. But it's definitely that kind of like rotational, torsional, like kind of shearing force through the hip with general day-to-day stuff that you can really pick up quite easily with those kind of questions with these kind of patients.
Cool. And then in terms of you mentioned FAI there, we talked about like OA hip as well. So like this, maybe if I shoot this over to Glenn, in terms of what's like the most common hip pathology you would see clinically, or generally, what are the sorts of classic hip presentations that you would see?
So again, I think this will come down to the setting that you're in. So as Mehmet alluded to there, I think one of the big things that makes me think hip is groin pain, particularly if it's been present for a long time. But if you're dealing with a lot of sports teams and someone comes in with acute groin pain, it's much more likely to be an adductor issue, for example. Looking at age again as well. So if anyone's kind of over the age of 45, I'd be veering more towards suspecting the presence of OA. If they're a little bit younger, you might be thinking more of an FAI. If they're female, it opens up a few more diagnoses as well. The possibility of dysplasia, particularly if they're have increased mobility around the hip as well. And I think if we're looking at soft tissue stuff, GTPS, lateral hip pain, really common presentation in MSK clinic, in the sporting and the non-sporting population, and hip flexor and adductor issues as well. So there is quite a bag of tricks to pick your way through, really, when you start to look into the hip. And to complicate it even more, if someone's had hip pain for 12 weeks or longer, then they're more often than not, they're going to have more than one issue, so they're not just going to come in with a purely painful hip. They might have some lumbar spine pain, they might have some soft tissue pain around the area as well. So then you have to try and work out, okay, which should I focus on first, which is the bigger contributor to their presentation, and educate them on each individual kind of presenting condition, really.
Yeah, and I think that's where the complicated nature of it comes in, is because hip, like I said before, and you just mentioned there, Glenn, hips do tend to come in with other stuff. There tends to be like, some lower back pain going on, or it's combined with other things. And I think Mehmet mentioned as well, and I think it's really important, is that obviously it's deciphering those ones and picking apart those ones that it isn't MSK, and then where there's other stuff going on. That's where you've got lots of, again, in terms of your lumbar spine and lots of other things going on around there as well, with the hip and groin and pelvic area. So I don't know, what's your thought process, Mehmet, on sort of differentials around non-MSK stuff? Are you, how are you think, those ones you mentioned there, where you feel like, something isn't right, like what's giving you that gut feel, or what is it about their presentations where you start to think, okay, this might not be an MSK problem, if that makes sense?
I mean, more commonly, it's the fact that it doesn't kind of fit into a mechanical type of presentation. So, like, let's take, for instance, Glenn's patient, like this, sportsman who's coming in with like a groin-related pain. Firstly, they're not going to be able to easily say, oh, like this is painful, and push to their groin. It's going to be a little bit more like vague, a bit more ambiguous as to kind of the site of where the pain is. The presentation of how that pain is presenting with as well, the duration and the site of where it is will vary as well in that sense. But then it will just give you the idea as to what other questions can we ask, if it is female, like have they had any like gynae related issues? Is there any change to their flow, to their period? Do they get more pains than normal? Are they getting abdominal pain, abdominal cramps? It's questions that sometimes you wouldn't necessarily think to ask if someone's coming in with what they are kind of self-diagnosing as a hip-related issue. But it's to us to not sell them a disservice and not be really thorough, because sometimes when things don't fit, there is going to be a diagnosis there. And with hips, it's interesting because it's one of those things that actually we still try and diagnose, which I'm pleased with. Like, it's one of those joints where we still try our best to get a diagnosis. Whereas with the back, it's now sometimes a bit like, can we effectively put a label on it or diagnose it because of like the clinical test and the research? With hips, we've kind of like, no one's really touched on that yet, which is fine by me, because I feel like actually it's one of those things that we need to know what we're dealing with, and we need to be specific with the diagnosis. Urinary tract infections are another kind of like, non-MSK type of presentation that may well present with lower abdominal pain or lower, groin related, even like kind of in the testicle region, symptoms that you wouldn't necessarily always associate with the hip or intra-articular hip pathology. And most certainly not like a lateral hip or an external hip pathology that you would see more mechanical type of symptoms. So if someone's suggested of those kind of things, and then they don't have the ones that we've spoken to about before, with the clicking and the giving way and problems getting in and out of a car, then for me, I'm thinking, okay, well, let's like delve into that a little bit more and just kind of like make sure that there isn't another, and let's kind of do the simple stuff first. So let's do the stuff that we're as clinicians good at, which is clearing the lumbar spine, assessing that properly, asking the questions about that, doing the same with the pelvis, and not thinking that, oh, I'm a, gynae surgeon or gynae consultant. You work within whatever your scope is, but let's try and tick off what we can. And then if there's other questions that are kind of bringing up, flags like those, delve into it as much as you can do, and then signpost to make sure that you go to the right place. Don't just kind of like treat in the hope that actually, it's not relevant or not, because, more often than not, those are the things that are quite important to get picked up.
And I guess
uh,
it's a lot of sort of also general healthy type stuff, isn't it? General health questions. So your classic kind of red flags in terms of, you know, fever, night sweats, you know, weight loss, all those things where maybe you might be thinking, okay, is there other stuff going on here of a more systemic nature, like cancers and other things of the lumbar spine, Mets and those sorts of stuff? You know, those are the sorts of things you maybe would be, you know, you wouldn't be expecting those, particularly in a, you know, a hip pathology patient. And if someone's got, you know, or post operation and they've got a lot of fever, then you could be thinking infection. So things of that nature, maybe you'd be thinking about with hips as well. So it's more, I guess, a lot of the times it's with the non-MSK stuff. I always think it's a lot of that sort of medical type questioning, often that on
yeah,
the special questions
yeah,
that you need to
exactly.
sort of go through.
Yeah, because someone might say to you, like, classic, you know, and you two are going to like vouch for this. You ask the patient, you'll say, have you got any like, what's your medical history? And you go through it and they're like, oh, no, nothing. I'm like proper healthy. I'm like Spartan. I have no problems at all. And then like nothing will fit. And then you're asking the questions and then out of the blue, it'll be like, oh, you know, I get a bit of irritable bowel or psoriasis or something kind of like inflammatory that you think, well, actually like that might have some role to play in this presentation. And it's those kind of things, actually, if you're not as experienced, you'll think, well, maybe that's, well, it's not relevant because it's kind of bowel related, but actually it's understanding that those non-MSK things are inflammatory. That might be a result of something. These presentations might either be a reaction of that in the hip itself, or it might be just visceral referred pain from that site into where this person has their pain. And it's just understanding and trying to pick up that kind of link or not. And it's hard sometimes unless you see it a lot, whether, you know, it's like what Glenn said, is it like the chicken or the egg, which one's coming first, and just trying to kind of decipher that really. But that just comes with time. The more you see anyway, the more kind of you get used to it.
I think
that kind of comes back to what you were saying, Mehmet, as well, about spending enough time on the subjective, you know. So with these kind of clients, it's not uncommon for me to spend 20 minutes going through these subjective questions and getting an idea, getting a good history. When we talk about red flags, obviously the obvious ones that we want to have on the forefront of our mind are, you know, remember SAM, stress fractures, avascular neurosis, possible secondary Mets. But then when you've got females, it is a lot more complex. And obviously we've got the whole gynecological questions that we need to ask, but obviously be mindful that we're not experts in that field as well. I think the one issue that can be quite confusing sometimes is a lot of these clients female clients will have pain during sex. So if that's one of your standard questions, that will come up in, I think it's over 90% of female clients with label pathology will have pain during sex. So that could be a bit of a confusing one when you're asking your specific gynae questions as well, but one that we need to be aware of because obviously has an effect on quality of life, right?
I guess with that as well, in my head now, as you say that, Glenn, I'm thinking, well, then the follow-up, because again, I think some people are worried about asking follow-up questions when it comes to that sort of thing, because we're, you know, people are just not used to asking them. But in my head straight away, when you said that, I was thinking, well, I would be wanting to ask then what position are you using doing that? Because obviously if you've got a leg out to the side and you've got hip pathology, then that could still be a problem. But if you're in a position where the hip isn't being particularly involved and you're still having problems, then maybe that is something more gynecological. So again, you clinical reasoning wise, it's kind of thinking about that and then trying to decipher. And I guess another question I have for both of you really is that I think with things like that over the years, I've always thought when you do have those complex ones that maybe you are suspecting gynae issues or you're just suspecting it just doesn't fit or feel quite right. I guess the big thing is having those links of where to send them to. Because often like I used to, especially when I was more junior, it'd be like you get someone you're concerned about or worried about, then you just think, well, what do I do with them? Like, where do I send them? Who do I send them to? Because they're there to be treated. It's tough, isn't it? Sometimes I think.
Yeah, definitely. And I think what you kind of, your first point about the position is key. And I think for anyone who's listening to this, that's, you know, it doesn't have to be junior or not, or they're just kind of looking to kind of progress. I think what was the light bulb moment for me, more so when I used to ask about red flags for lumbar spine, you know, asking erectile dysfunction and, you know, numbness, like vaginal numbness, that kind of thing. I mean, it's awkward. Like, we're all human, we're all adults. It's an awkward thing to ask someone. it's not awkward if you explain why you're asking it before you ask it, and you frame it. And I almost go about it in such a long way explaining what I'm about to ask about the anatomy of what it is, where it is, why I'm asking, that by the time I ask it, they're like, oh yeah, it's fine. It's like, I understand why you're asking me. So when you're asking about like labral issues and positions, you could just easily just say to them, well, look, you know what, actually, this is what the labrum does. There are certain positions when you put your thigh in this position that can irritate it. Obviously, that could be replicated during sex. Like, what, this is, I understand we're both adults, blah, 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 explain it to them. And actually, so much of that alliance with the patient will be built in with those difficult conversations. And if you ask it confidently and they know, actually, look, this guy knows what he's talking about, you're already going to help your outcomes further down the line, because that's when these links are being built. What was the second question? This is what happens. I told you, you start asking about hips, my brain will go like, what was the second point?
No, it was just kind of like, where it's quite hard sometimes where to send people. If you're worried about them,
right,
where would you send them? Because it is one of those things where, because also you have quite a few patients, I had quite a few patients over the years where it isn't black and white. It's not like they come in and they go, I've got night sweats and fever, constant night pain. I've had 2 stone weight loss in the last 2 weeks. Like, that isn't how these people present. They present in a much more innocuous kind of like, something just isn't right, but actually they've still got some symptoms that you could fit in. Like, it's not really, I've probably had a few black and white ones in my career, but not many. A lot of the time it is a mixed bag. So I guess it's like having those links with people where you can go to people, senior clinicians or other members of staff, other members of MDT. But like, when I was a junior, I never used to know where to go. So I just wondered whether you had any ideas for juniors out there or people who are learning their craft. Like, what would you advise them to do if they did have one of those sort of, mixed bags where they're not quite sure?
I'd say it would be good to know, to have different links. Like, for example, if we're going with the gynae link, for me, it's not my area of expertise. I don't know a lot of it. So lucky for me, I've got a women's health or pelvic health specialist physio in my team that teaches me stuff that even now, like, she'll kind of like tell me stuff, and I'll think, oh wow, that has a massive link for those with hip pain. I didn't know that pregnant females who have given birth naturally, every time they give birth, the percentage of a vaginal prolapse increases by like 30-40% or something. Now, to us, as when you talk about hips, you think, well, what difference does that make? Well, actually, that has a massive impact on like the stability around the pelvis and the hip, which can then have an impact on how things present or how things can get worse. And these are questions that I ask now that I wouldn't have necessarily. Obviously, I ask them just whether they've got children or how they've given birth. But those are things that necessarily I wouldn't have asked before had I not picked up the fact that actually I need someone who is a women's health specialist to liaise with. But actually, having real good sports and exercise consultants that you're linked with are going to be a massive help to anyone who's like a junior or younger physio that they might be working on their own. They might not have senior clinicians. It depends on like I guess like what Glenn said, it's where you work and people that you see and what you're surrounded with is going to vary. But I think so long as you've got senior clinicians, and if you don't have that, sports medicine consultants that I've worked with and that I'm even in contact with now, I'll text and WhatsApp and send direct messages of cases. And, I find it really, really helpful just to get a different perspective that sometimes isn't it the physio as well, because it gives you that kind of like medical mindset that we sometimes don't do. I mean, Glenn, because obviously you're within your clinic, how's it kind of?
Yeah, I mean,
you got your links as well, I guess.
Absolutely. I mean, I think that's one of the major challenges when you're specialising in the hip. Actually, is to establish that network, because you do need a good link with various surgeons, consultants. So you need high volume surgeons that are doing the hip arthroscopies, but there's often it's different surgeons that are doing the PAO kind of surgeries. You have links with guys that are doing earlier hip replacements and things like that. So I have several different kinds of surgeons that I will refer different clients to if need be. I also think that in the hip, it's a little bit different to the lumbar spine in the sense that you can justify imaging a little bit more commonly. So we can't get an accurate diagnosis with just the clinical tests, although you can get a strong idea from the subjective and the objective tests combined, but you can't say with 100% accuracy that it's definitely a CAM presentation, for example. So there's a little bit more of a justification for imaging. So if you are worried about red flags, stress fractures, or possible METs or something else going on, then I wouldn't hold off on referring them for imaging as well, you know. So I think that the hip's a little bit unique in that sense, where there seems to be a bit of a trend for, you know, not getting a diagnosis and going away from imaging. But the hip, I think, not saying that I image everyone that I see with a hip presentation, but there is a bit more of a argument there in a lot of instances compared to other areas of the body.
And you mentioned there about objective tests, so that kind of brings me on to another one of my things I wanted to ask about. So, you know, what value do you guys put on clinical tests? Maybe Glenn, if we go to you for this one to start with. So, yeah, what value do you put on them, and are there ones that you would classically use? And again, for sort of junior physios, what are the sort of staples in terms of an objective assessment to sort of be ruling in or ruling out the hip?
So again, I think probably the easiest thing to do is to rule out the hip, you know. So a lot of the clinical tests that we do will be painful for a variety of hip conditions. So I think if we take the Fabers test, the flexion, adduction, internal rotation test, that's got fairly high reliability there on, you know, provoking pain in the hip joint. And if we combine that with a Fabers and with a resisted straight leg raise test, if none of those are provoking their pain, then we can be fairly accurate in ruling the hip joint, you know, out as a source of their symptoms, I would say. So that's a lot more easier to do. If we're looking at, you know, trying to identify painful labrum, for example, we've got tests like modified Thomas tests and Fitzgerald tests, and these are always associated with catching and clicking and pain. But, you know, it gets a little bit harder to say, oh, it's exactly this structure that's causing that pain when I do this test. So it's much easier to rule the hip joint out. You know, I think the caveat there on the Fabers test is that we're talking about groin pain here. As I'm sure you're aware, the Fabers was designed for SIJ pain provocation, but when we're looking at the hip, it's a very good test for provoking pain in the hip joint pathology as well. So they're the sort of main tests. Obviously, if we're looking at extra articular structures, then we generally will palpate them, we'll load them, we'll stretch them. So, you know, you can do those in a variety of ways. But yeah, I put a lot of emphasis on clinical testing. I totally agree with Mehmet. I think you've almost got an idea in your mind as to what you're going to see with those objective markers from your subjective discussion that you've had. But we do need to go and test that and see what comes out. And I think one of the big things, and this isn't so much a clinical test, more of a clinical practice, is working out someone's hip profile. You know, so a lot of the time, I don't think this is done commonly enough. So looking at, do we think, you know, do they have an antiverted hip profile, a retroverted hip profile, a lax hip profile, or a normal kind of profile?
So how would you do that?
So clinically, I would lay them on their back. I'd take the hip up into 90 degrees, and I'd gauge their internal and external rotation that they have available here. So this is more of a kind of a clinical test, if you like, and be looking at about 30 degrees internal rotation, 40 degrees external was, you know, textbook kind of normal. If they're antiverted, you might see, you know, somewhere like a 60 degrees internal rotation and only a 10 or 15 degrees external, and then the opposite for retroverted, they'll have much more external rotation and reduced internal. Now, again, this isn't the most precise of tests, but it gives you an idea. And why I think this is important is because it will dictate the kind of positions you put them in when you get them to do your rehab exercises, like your squats and your deadlifts and stuff like that. So I find that
would you do that on there? Because obviously pain is going to inhibit often, and pathology is going to inhibit their range, like generally. So would you do that on their good side in order to sort of work that out, or how would you? And then obviously the next question, which is a difficult one probably, but comes is bilateral. Like, what do you do if someone's got bilateral problems?
Well, you'd always test both sides. Where it gets even more fun is sometimes they can have different profiles left and right as well. And normally what you find is what is on the painful side is replicated on the opposite side a lot of the time, apart from dysplasia that can be unilateral. But yeah, so for me it's more about getting an idea of where their hip likes to be, you know, so that if they one of the big issues I've seen with squatting, for example, is a retroverted kind of hip profile that is very comfortable in a kind of sumo position when they squat. Having a trainer or a physio or a PT telling them, oh, you can't squat like that. You have to have your feet shoulder width apart, your knees shoulder width apart, and kind of forcing them into a position where they're not that comfortable, you know. So when you're giving them their rehab exercises, being mindful of what their underlying anatomy prefers is really important, I think, and that's not commonly done, I would say.
Yeah, I think that's a really good point and a really interesting point. And I think the thing that interests me as well about that, though, as I think about that, is it's a difficult one. I don't know, maybe you want to come in, or both of you, but like, how do you? It's difficult sometimes to work out. Then, how do you push their mobility? You know, we talk about mobility drills and increasing mobility, and all those sorts of things. So when do you push someone into that and sort of stretch them because you want them to increase their mobility, or when do you then not do that because of what you just said, Glenn? Do you know what I mean? There's that middle ground where you're like, well, if they're immobile in that position, maybe they should be pushing it into that a little bit so that they can actually gain a bit of that mobility. Or would you tend to steer on the put them in a position they like, do it like that, and only would you ever push them into those positions, if that makes sense?
I think it depends on what movement you're looking to increase. So if someone is restricted in internal rotation, for example, and they're playing football, so it's quite common to see a footballer that's only got about 10 degrees internal rotation, they're getting groin pain, confirmed FAI, that kind of presentation. It's unlikely that you're going to significantly improve that internal rotation without surgery, actually. So most of that internal rotation is dictated by the bony morphology. So without a change to that, it's unlikely that you're going to get a drastic change. You might get a few degrees here and there. So you might be able to compensate around that. They might be able to still perform and still compete without surgery, but it's not a realistic goal to think, oh, I want to get him to 30-40 degrees internal rotation by doing some mobilizations for movements, or for example. So
I think that's a really interesting, like a really important point, because I think some people, physios, especially junior physios or younger physios, might think they need to, normal is this, I need to get them back to normal in order to do well. But actually, in those situations, you could be making things worse.
Yeah, and I think the caveat there is if they are attending post-op arthroscopy, then you should be able to gain a bit more internal rotation. So you have slightly different goals if you're treating them conservatively versus post-op, and depending on the movement, So there is research to show that you can improve the general range of the hip and get good outcomes there. So you might want to, rather than focus on internal rotation, you might try and improve extension, external rotation. So you could try and improve the general range of the hip, without provoking them. But yeah, I mean, what's your thoughts, Mehmet, on that?
Yeah, I mean, look, it's ultimately like a movement disorder anyway. So like it's or motion sort of. So it's easy to, I guess, in a way, adapt. Like you said, I think the thing which really grates on me, and I see it a lot on Instagram, is that people's obsession with internal rotation without any kind of like justification at all. So what that means is, like, you could, for instance, go and have a look online or on YouTube or on Instagram, and you'll find that the fix for hip impingement is to like do internal rotation drills. Now the problem with that is that as soon as you start, if you have FAI, if you have a bony morphology or a cam or something like that that's in the hip, and you start trying to push through at the end of range, you get essentially like what we know is like a micro instability in the hip, because it's basically like pushing the head of the femur out of position. And this is like not much movement, but enough to repetitively over a period of time is going to have a detrimental impact on that hip, and it's going to hurt. Like people sometimes think that if you push into it and it hurts, it's going to do it, like it's going to help, but it's not. But like Glenn said, if you had surgery and that block isn't there, but actually you could potentially work into that. But it takes a skill to know how much to do and when to do it, and actually the timing of like post-op when it's necessary to do as well. With that as well, I think you see a lot of people like in that situation where they're doing the internal rotation, but they're also trying to like almost like distract, like self-mobilize with a band or well, more often than not, it's like the TheraBands, or not TheraBands, the
kind of CrossFit
like
bands.
like the thick resistance bands. I wanted to have a little look into this because I spoke to a consultant, and like I thought I wanted to know specifically the force that it takes them to move the hip out of, you know, when they're like distracting the hip. And it's basically the equivalent of an 80 kilogram deadlift, the amount of force needed to just distract the hip. That was about 8 millimeters or so. So if you think someone's in the gym and they've got the band around their leg, like they're not going to be doing that. And it doesn't mean it's bad for them, but I think what annoys me is like when people package it as like an elixir of hip pain and it's going to do the job, because actually it won't really do too much. You know, it might be very transient, the impact that it has. But yeah, I think the focus should far, and yeah, like I think what Glenn said at the beginning in regards to looking at their profile and trying to get an idea into what their rehab's going to be like, Chris, because obviously you mentioned like with the squats and the sumo squats, like is that something we'd look at? And I would say so, like right from the beginning, because if you can modify something for a patient that's painful and they say into you, okay, I can't squat because it hurts, and then you get into the sumo deadlift or just a sumo bodyweight squat, or even a sumo sit to stand, and they're like, oh, actually that doesn't hurt as much. You've always like verbalized your clinical reasoning to them, and then they can see it, and they're like, oh, like why doesn't that hurt as much? And then it's just basically everything Glenn has just said, in the fact that, you know, discussing the morphology of the hip and the pelvis, and explaining, you know, this is why our rehab's going to maybe be different to what you've done in the past. Like actually you could get back to all your sport that you're doing and all your strength and conditioning. We just might have to tweak one thing, and actually you might not be able to do like the squats like you used to, but actually we could probably get even stronger doing them this way, and your hip won't hurt, and then you can play sports. So it's just like, it's a kind of a, I don't know, hips are a bit of an adventure, aren't they, Glenn? It's kind of takes you on a roller coaster of like trying to convince people to change how they do things, but you know, knowing what's best for them as well.
Be interesting to ask you, Mehmet, as well. The other issue I have with like you say, some of these kind of Instagram gurus that are like telling people to drill into internal rotation is, a lot of these clients will often come and say, you know, for a few years before it became problematic, they felt a pinching and a tightness and a restriction in their hip, and they tried to force into it. And that's a really common story that I hear with my hips. Did you experience that with yourself? You know, when you were playing football, did it feel like just generally tight, not stopping you playing? And then progressed over it.
Yeah. And it's so common. I think that, like you said, I think with you know, with dysplastic hips, it's good 5 years before diagnosis. With FAI, it's commonly, you know, I'd be surprised if I don't see one pre-op that's not been ongoing for like a year or so, because it doesn't, you know, unless you had something really traumatic. We know that the bony changes have been there from adolescence. So actually, if they're like 25, 30, and you know, this labral kind of, we could just say like the integrity has started to change from those bony FAI changes. Yeah, it would, like, it's just a gradual thing, isn't it? And it's just like a bit of groin stiffness. That's exactly what I had. It was like a bit of groin tightness. Obviously at the time I didn't know it, so I was trying to do like groin stretches, you know, as much as an 18-year-old Sunday league footballer would do, which is like, to be honest, not that much. But yeah, really common. It's a weird situation to be in when you're the patient, and now you kind of see it day in, day out. It definitely helped me. I wouldn't suggest anyone wanting to specialise in hips goes and has any hip surgery just to improve their empathy, but it's always a good insight.
We might come back onto the surgical bit, because I think that is an interesting thing to talk about. But you mentioned, both of you mentioned rehab there, so I think maybe that's a good segue into the rehab of hips. And maybe if we split it up into a few different like types, because obviously there's so, you know, rehab is, you know, it's going to be dependent on the person. I think podcasts like this it's difficult sometimes because it's always going to be dependent on the individual. So it's just trying to give more sort of generic advice and tips. But if we take like more of your articular, your FAI, dysphagia, those types of patients, what's your kind of go-to thought process of rehab? Are there any specific go-to exercises you use? Are there things that you commonly find that you think are really important to work on? Like, what's your kind of thought process around the rehab process?
I guess it varies, like from whether they're pre-op or post-op to start with the FAI hips, for example. Those who come to see me who haven't had surgery, or they might not have the opportunity to see a consultant or have surgery because they're self-funding or whatever reason. But I'll always kind of like make sure that their assessment to start with is key. Because I think if we're going to start creating a rehab program, I'm not really one to give exercises unless I can really justify why I'm giving it. And I can't justify it just because they've got a condition. I need to justify it because actually they've got a strength deficit or a movement impairment in a certain way, and we'll try and focus on that. Now, I think this is where the pitfalls of FAI research falls a little bit for pro physio, is the fact that it's so unique and tailored per individual. Like what Glenn said, like, are they retroverted? Are they antiverted? You know, their age, the level of, you know, labral issue that they've had. And it varies so much. So to the point where actually when I'm prescribing rehab, it varies quite a lot. Now, everything I do for these tends to be rehab based, and that's just my preference. That's just kind of how I work. I tend to focus a lot on strength and conditioning, a lot on trying to educate the patient as to the things that can potentially irritate the hip, ways to avoid that, and then modifying their rehab program going forward. So that, you know, that takes a little bit more time. It's sometimes hard to fit this all into one session, so we usually spread it over two. And I think that's a really key thing. I think the outcomes for these patients can be long. The rehab process can be quite long. And even if they are going to need to have surgery at some point, we know that they're actually going to be better off having had that rehab. And even the research from recent, like the last year's research, does tend to say, you know, rehab it for a good 3-4 months first before, you know, surgery, because the outcomes will be better. And also the patients will know what to do going forwards. It's hard to specify like specific exercises. I probably wouldn't be able to be specific with that, but I would definitely start off by trying to improve their strength capacity with bilateral exercises, you know, double-legged exercises. And then once we've got their idea of their 10-rep MAC testing within their rehab, we'll try and implement that into single leg loading and single leg. That, you know, that could be a multitude of different things, really. I know it's a bit I'm being a bit vague on purpose.
No, but it's more you're thinking about like looking at their movement patterns, finding a way that they can strengthen their lower limbs without causing pain, without aggravating it, offloading those things that do aggravate them, and then building up their strength bilaterally and then unilaterally, and kind of going through that process.
Exactly.
Basically.
And I think the key with FAI is to be really aware of like the synergists within the hip and pelvis. So, you know, if you're going to think within their program that you're, you know, going to focus on their glutes, to, you know, for a period of time, then actually you need to be aware and include things within their abdominals and hamstrings as well, and just to kind of have a combination of those things, and just make sure you've got quite a robust and you know, varied program. It's no good just kind of like focusing on one muscle group and not working in multi planes of movement and within that synergistic framework, really.
Do you Glenn, if we perhaps ask you this, do you tend to go with like isolation exercises when someone is quite aggravated and then bring in more of the functional stuff? Are you someone that sort of goes down the route of functional stuff without pain to start? Like, how do you think about it?
Well, it's similar, you know, I like sort of processes and things like that. So I will start them at level dependent on their irritability more so. So if they're really, really irritable, you know, I use sit intolerance to gauge the irritability a lot of the time. So if they can't sit for 10 minutes and they've got night pain and all the rest of it, then yeah, I think the starting point would be more kind of, you know, mat based and clinical Pilates kind of exercises in that early stage. But I love the gym. I'm always aiming to get them back in the gym. So as they settle down and the hip becomes a bit quieter, and we're using that time to educate them on their pathology and the time frames and how it's going to be a bit up and down, which I think is important to tell them as well. Then we start to add a bit more load using, you know, bands, stuff like that. And then when we take them in the gym now, I take a slightly different approach to Mehmet in the gym, because I don't individualize it quite as much, I suppose. So I'll have the main lifts and I'll load them in order of irritability. So if they're irritated by a squat, then that will come in last, for example. So I might start them with a stiff leg deadlift, you know, I might start them with a hip thruster. So I'll pick the big main lifts and I'll load them quite heavy in the areas that they're not provoked in. And then as they strength builds, I'll bring in the more provocative exercises and I'll modify them slightly. So, you know, as Mehmet was saying, we'll aim to get them back to squatting, but maybe not squatting as they was doing prior to their onset. So using things like TRX squats and goblet squats and front squats and, you know, different leg positions, and maybe not going quite as deep, And I'm a big fan of the hip thruster, you know. So
Yeah.
and again, if someone's into their training and they sort of are rightly telling you that they want a deep squat because it gets more glute activation, for example, I can always justify that to them. Okay, we're not going to squat quite as deep, but we're going to add in a hip thruster that gets, you know, maximal glute contraction. So they're still getting that best of both worlds, really, and they're just not irritating the hip. So yeah, I have a bit more of a kind of, it's more based on irritability, you know. So I suppose it is individualized in that respect, but more often than not, they end up going down the same route in terms of what lifts I add in first and what lifts I add in at the end. But I think that's the big change that I think me and Mehmet both do that a lot maybe don't, is getting them in the gym and loading them, you know, reasonably heavily.
Yeah, but you mentioned quiet hip there, and I think that's like paramount for post-op as well, pre and post-op. I think people kind of the way, especially with the post-op scopes, is so easy to irritate it unless you do the right things at the right time. And I think, you know, the quiet hip for me, I give them a good few weeks just to kind of do all of those things, just to kind of, because otherwise, I think the problem is things post-op with FAI or hip scopes could present with the same pain but not be the same thing. And and sometimes as a patient, it's really demoralizing to feel that. Like if they end up getting, you know, like a hip flexor tendinopathy or something like that, it will feel like the same to them as a patient, and it's really like disheartening to get that. So I kind of focus almost like less is more sometimes, isn't it, in those early stages? Almost just like even working on stability, just to kind of give them something to do. But I guess that's and this is great why we do things like similar but in a different way. And I think that's you know, just need to kind of keep banging this drum to people, because I think sometimes if you just keep doing the same rehab, that's limiting sometimes when you don't have the gym, because not all physios do, you know. Like I'm aware that actually we're lucky when we've got gym stuff at our disposal. We, even patients, don't have access to a gym or don't have much equipment at home, and that's a challenge, you know. There's no point saying to them what the breast research shows if they're saying to you, I've got a 10k kettlebell, make it work, because it's our job to try and create and be like innovative.
So what do you say to those patients? Because guaranteed there'll be physios listening to that, what you just said there, and be like, that's my daily life.
Yeah, well, I would tell them to invest. I'll be honest, and I'll say, look, if you can invest your money in yourself, you'd be better off trying to spend 20 quid to get a gym membership, where you can do some of the stuff that I'll give you to do. I'm lucky in the sense that, you know, I'm in a hospital, but I also have access to a gym, so I'll, you know, see those patients there. But if you don't have any of that stuff, I'd say, one, try and be innovative within the clinic environment, within whatever weights and, you know, things that you have, but also try to I guess like try and like get them to invest in things that you can utilize with them. So even if it's like a dumbbell or a kettlebell, like Glenn said, you can get like secondhand TRX, things like that. That will help them in the long run. And, you know, sometimes people will be all up for that, because if you say that, you know, we can utilize it quite a lot going forwards, then that'd be fine.
I think it's just, like you say, it's honesty, isn't it? Like, I think, again, sometimes physios don't want to have those difficult conversations. And I think that ultimately, sometimes you just have to have that difficult conversation where you say, look, you know, if you're not willing to do that, you know, then ultimately your rehab is going to be worse. Like I'll give you the best advice I can give you with the equipment that you've got, but I'm going to tell you now that is not going to be the optimum of what you could do, and you would be better off by doing the gym. And obviously, the way you say it to patients is not in a sort of finger pointing, like, you blah blah blah, I'm the expert, you should be doing what I'm saying. But equally, I think it is important to be honest and just say, look, it's same thing with timeframes. You know, people want to hear, oh, it'll be better in a few weeks or whatever, but ultimately, sometimes you have to say, look, this is going to take 9 months, 10 months, 12 months, 18 months to get back. And I think that actually in the long run, a lot of patients appreciate that more, because it's actually a situation where you're being honest with them, and then they're not going to get false expectations of the way it's going to go. It kind of leads me on to, I guess you mentioned it as well, in terms of, you mentioned surgery a few times, but in terms of when is it that you would seek that ortho opinion? So maybe Glenn, if it come to you, are there, you know, if you're struggling with a hip patient, what are the things in their history, or, you know, as you're treating them, what are the things where you think to yourself, do you know what, I need to get an ortho opinion, or this might be a surgical candidate, basically?
So I think it comes down to their goals. I mean, just touching back on those last points, one of the benefits of working with this group of clients in general, the kind of younger hips, is they are very motivated, I would say, so that you don't see sedentary people presenting with these presentations. So they normally are very compliant with gyms and stuff like that on the whole, so they tend to be exercise minded, and that's their passion. So that's why I do like working with these individuals, and it also makes them a challenge because they've got ambitious goals a lot of the time. So that's one of the big factors for me is, are they meeting their goals? So I think as a very general rule, Mehmet's already touched on this, but we should be giving them minimum 12 weeks of good structured rehab before we make any of those decisions, I would say. So I think a lot of the time people don't allow them time for the hip to settle down. They try and rush it. They're not getting any better in 4 weeks, so they try and rush the referral onwards at that point. So I think we have to have those timescales in mind, that 3 months, 4 months is a good amount of time to spend with these clients. If at that stage you're not getting any meaningful improvements and they're not getting back to their goals, and there's no underlying arthritic changes and stuff like that, then I would be referring on at that point. So we do know that surgery is a good option if the rehab is failing. So I wouldn't hold on to them for a year plus either on the flip side of that. So 12 weeks, 16 weeks, good enough time. If you've done logical rehab, you've taken them through the stages, you've settled it down, you've tried to load them up, you get one or two things. So either they'll modify their activity. So I've had a few where I used to play hockey, might be provoking it with hockey, but they might be getting to a point in their life where they're like, what, I've got kids, it's, I'm not that bothered as long as I can train. And then they'll modify their activity and just replace it with gym and running or something like that. And that's enough because they're not doing the bending and the twisting. Or they're like, no, actually the hockey's a really important part of my life. It's my escape. It's my stress release. I want to try and carry it on for a few more years. So you can get decisions made via the client as well, because if they modify their activity, often you'll get a good outcome conservatively. So it all comes down to their goals and their presentation, I think, so we don't have the evidence to suggest that we're going to be protecting them from arthritis, for example. So for me, it's all about what can we improve right here and now for your sport, your activity, your quality of life. And if I'm not achieving that with conservative rehab, then I refer them on at that kind of 12, 16 mark.
That's similar for you, Mehmet, with surgical type referrals, etc.
Yeah, I would say pretty much like that, the same as what Glenn said. Everything he alluded to, I'd be the same with that, because there's no need to drag it out. I think sometimes people think that the longer you do it, the more chance there is that it's going to recover quicker. But sometimes these patients need surgical intervention or at least consultant input in one way or another. So I say, sometimes we need to get them involved and just get within that decision-making process. But again, it comes down to whether you've got that available to you or not, really.
Okay, cool. And then last couple of things, and then I wanted to quickly chat about your experiences with surgery, because I know you both had surgery on the, well, not necessarily on the hip, but surgery. And I think it's always interesting to get physio's perspective on rehab. But in terms of things, are there things in the last few years or so that you've learned with the hip, for example, that you think are really key, where you were like, I wish I'd learned this 5 years ago, or the things that people maybe don't know that maybe they should know, or just some key tips maybe for people in terms of treating and managing hip patients, Mehmet?
Yeah, I think with this, I'll probably make one point, which is it's quite easy for us to associate biopsychosocial physio with people with back pain, and it's easy for us to forget that these hips are part of people, even those who are young athletes. And sometimes we kind of think that these situations only present themselves those people who've got persistent, who are struggling with work and stuff like that. But actually, if you've got a young athlete who's in their prime of developing, or is even an amateur athlete who is, you know, for their mental well-being, like trains a lot, and that's their out. Actually, if you're kind of thinking that they're potentially going to be off for a long period of time, or you're rehabbing them, it's quite easy to just like forget that. With just, you know, I'd say definitely a little bit more focus on that side of things and treating anyone with hip pain, not only those who are you know, in a slightly older demographic that we commonly would associate those things with, but actually even with the younger population who are kind of going through these things, actually they need a little bit more kind of emotional support from us as physios as well. They're almost like acting as like their like coach as well as their physio. You're just being a bit more aware of that, if that makes sense.
Totally, yeah. What about you, Glenn?
I would 100% agree with that. I would say if I can count the last kind of 4 or 5 of my clients that were in tears at some point, they're all hips, you know. So it is a very difficult condition for them to deal with. A lot of the time they've been dealing with it inappropriately, or they've not been getting the help they need for a couple of years. It stopped them doing their sports, their hobbies, their activities that they're really passionate about. So emotionally, it takes a lot of energy out of you dealing with large proportions of these clients, you know. So they do need a bit more time. They do need a bit more education, a bit more input. I think one of the big things that if I could go back and do differently would be just being aware of the expectations and the outcomes as well. So the hip's quite unique in the sense that even if you get a good outcome from surgery or conservative management, it will never really be 100%, you know. So they still always have a little niggle, but it might be that it was 8 out of 10 and you get it down to 1 or 2, but it's very rare that you'll get them down to, you know, that they'll be comparable to someone that's the same age without a hip pathology. And that can have a big input on someone, you know. So if you're going into a surgery that I often liken to an ACL reconstruction in terms of how long you have to put in for your rehab afterwards and the ongoing nature of the rehab after that. When you send, well, certainly when I send someone through for an ACL, for example, I'm expecting to get them back to sport, you know, 100%, you know, feeling that knee back to how it was, you know, pre-injury or better in some instances. But with the hip, they need to be aware of the fact that they'll get, you know, significant improvements a lot of the time, but it'll always be there, you know. There'll always be a little bit of a niggle compared to someone that hasn't had a hip condition, you know, of a similar age. And for me, that has a massive effect on their expectations. If they're told that early on, then they're much more satisfied with their outcomes later on, you know. So I think that's a one that I would educate people on and do a little bit differently on my, you know, first however many hips that I saw. You know,
I mean, both of ours are like psychology-based points to make.
Yeah, but it is fascinating, isn't it? And I think the point that you make about the biopsychosocial approach, yeah, it's so like well known in backs, and we know, you know, you guys know as well as any good physio that actually that those effects happen in all sorts of body parts, hips, shoulders, elbows, all sorts, you know, all sorts of stuff. That is a big part of it. So I think we can't forget that is a huge component. And then the final thing I wanted to ask you both was, obviously you mentioned, Mehmet, that you had surgery on your hip. I know, Glenn, you've had ACL surgery recently. So like from your experience on the other side of things, how did you find that? Did you, you know, were there any things about that process that you thought could have been done better, or like, you know, physio wise, you know, what was your sort of experience of it?
The hip surgery it worked great for me. I mean, that's probably half the reason why I ended up doing what I do, just because my recovery was quite poor. I don't think I could run for about 18 months, 2 years. It didn't work out that well for me. I don't know if it was just because it was so early into like when these were getting done, and also I was probably a rubbish patient. Didn't really rehab it. I probably rehabbed it too hard, too quickly. Went back to work too quickly. I think I went back to work after like 4 weeks, like going back to full clinic, and then I was doing like full day at night. I just think I did too much too soon. So that wasn't that great, and it definitely kind of like gave me an insight as to how like you need to manage those a little bit better. The physio back then for me was, I mean, bearing in mind, this is 10 years ago. So, I mean, it was all right. I mean, it definitely was like exercise based, but there's also a lot of like trying to release my psoas and seat belts and stuff like that. And, you know, that's I just remember it hurting a lot at the time, and I remember being in pain all the time, and like nothing really helped. And it was random. Like my pain went one day. I have no idea why. I have no idea why my hip stopped hurting. I didn't do anything. I wasn't doing anything any different. I just remember one day I woke up and I was like, oh, like it just doesn't hurt. But what I have noticed is I changed, like my stride length was shorter. Like I wasn't moving like I used to. And I think that the kind of long period of time just took my body naturally a period of time to adapt to what it was naturally, what it could do without it irritating. But that's just, that's how things are. Things are a bit different these days. My back was fine. My back was easy, mate. It was a walk in the park. It was fine. I had no pain. It was completely better. But yeah, again, like don't advocate surgery, by the way. People, if they've got back pain.
Yeah,
worked for me.
But I think that's the interesting point, is that obviously we know that surgery is not what people want, and we know that it's like a last resort, but ultimately sometimes people do need it. I've had my ACL done. I know, Glenn, you've had your ACL done, and ultimately surgery works for a lot of people, and it's not the panacea for some people. It doesn't always work, but at the same time, I think as physios, sometimes we get on this kind of like anti-surgery bandwagon where it's like, oh, don't have surgery, blah, blah, blah. But actually, sometimes people do need surgery and they do need these things to get better. I know, obviously, Glenn, with you, like getting back to your BJJ probably couldn't have happened maybe without the ACL, or certainly you would have really struggled.
Yeah, I mean, for me, I'm totally happy that I opted for a reconstruction. Yeah, so I had an unstable knee for several years. I had a couple of instances where it gave way on me. It first started with judo, and then I self-managed it and rehabbed it myself. And I got back to like snowboarding and Brazilian jiu-jitsu, and it was doing okay. But then I started to train mixed martial arts, and it was kind of twisting, pivoting, classic kind of movement, and it was pretty dramatic on that last occasion. So it also tore my meniscus, and it fractured my tibial plateau, and whatever was left of the ACL was gone as well. And yeah, so for me, I never had it scanned before. I suspect maybe I'd ruptured it prior, but my knee was, I didn't fully trust my knee. Funnily enough, when the injury happened, it was the most I'd been trusting my knee for multiple years, but I couldn't run more than 5-6K without getting knee pain, for example. And after having the surgery, I got back to boxing, Brazilian jiu-jitsu, mixed martial arts in controlled way. I have done a half marathon, so my knee is stronger and better than it's ever been, really. So for me, and I noted the rehab was very similar. I did my own rehab before, I did my own rehab after, and there wasn't much change in that, really. I did a bit more plyometrics after the surgery. But overall, my knee was pretty strong before, it was pretty strong after, and I can feel a noticeable improvement in stability there, from having the surgery done, and I trust it a lot more. So for me, it was a real positive. So, and a great learning experience. So, as well as hips, knees now, as much of my case is ACL rehab, because that's my kind of new passion since my surgery. It's been 2 years now since my surgery, so
That's crazy.
Yeah. So
that's crazy. Like Mehmet said earlier, though, like I think we all, as physios, you're interested in the whole topic, but then when something directly personally affects you, you tend to like look into it more, and it's like it's always one of those things.
I think that's why I draw a lot of comparisons with hip arthroscopies and ACLs, because I think there are a lot of comparisons there, time frames and the importance of the rehab, the importance of taking them to end stage rehab, and I'd say the difference is just, with the knee, it tends to be a lot more of a linear progression. So, from week 1 to, month 6 or whatever, it's a fairly consistent improvement line. Whereas with the hips, it tends to be a bit more kind of up and down. I think you'd agree with that, Mehmet.
Yeah,
So,
yeah, definitely.
But hopefully trailing along the same trajectory, but just with a few more, flare-ups here and there a lot of the time with the hip for whatever reason. So, yeah, but you get the same kind of people in both groups, dedicated, motivated, healthy, athletic, and you spend a similar amount of time with them, really. So you build up a good rapport, you get involved with all their goals and all their, ideas, which is what we do it for, isn't it? It's what I do it for. I love to see people back on the field playing football or back in the, you know, the ring or whatever it may be, whatever their sport. That's the goal for me as well. You know, that's what I get my that's what gives me my kicks from the job, you know.
Definitely. Cool. Well, I think it's getting to about that time. I've taken up a lot of your time on a Sunday morning, both of you. So I want to say massive thank you to both of you. I thought that was really interesting. I think hopefully physios will get a lot out of it, and a lot out of that chat. So it's been good. I know you both do hip courses. You both got sort of social media and stuff. So if we come to you, Mehmet, first, where can people, you know, look into your course? When can they look into your, you know, social media, and what are your handles and things?
Yeah, so my website's thehipphysio.co.uk. Any more details? My Instagram handle is the.hip.physio. Very original, I know, but seems to do the trick. And then feel free to message me. Anyone who watches this or listens to this, feel free to get in touch in any way, you know, via the website or via my Instagram. More than happy to kind of chat to anyone.
Perfect. And Glenn?
Yeah, so I need to be a bit more active on social media actually, but yeah, I my Twitter's at Hemel Physio. My Instagram is Physio Academy. Most recently did my hip course through Club Physio, but I'm going to be launching a newer version of that through the Physio Academy website. So best to just link up on Instagram and Twitter, and we can keep you updated on there.
Yeah, and I'll put, obviously, I'm going to, in the show notes to the podcast, and in the description, if you're watching on YouTube, I'll put the links of all your stuff on that. So both of you guys, I'll put your links on. But yeah, thank you very much for doing the podcast today, and hopefully we can maybe have a chat in the future.
No, look, thanks for having me.
Lovely, thank you.
Sounds good.